very closely, and I'm going to leave it up to him to lead and start the session. Professor Baird.
Good morning, Paul and John. And I think I'm unfortunately placed in 3 halls, so I will be going in and out, and I would like you to excuse me. So, anyhow, Paul, as John said, we had our the what talk he's going to give, the keratoconus International Consortium. We had the we had the meeting in Mumbai on February 10th. I hope Paul is going to talk about it.
Yes, thank you, Dr. Sarjan.
We'll represent you here.
For the invitation. Yeah. Aha, here we go. That's better. Okay, so what I want to do today is really talk about what you can do with collaborations around the world, and how this can be used for the betterment, I guess, of understanding a disease. So I'm going to talk about keratoconus. And some of you may have heard of this, some of you may not, but this is an example of something that we're doing with a corneal disease. So just to give you an idea, this is, if you see a side view of the cornea, it looks pretty normal, whereas once you move into more moderate advanced disease, you can see this nice sort of protrusion of the cornea sticking out. And I think anybody, and not as a non-ophthalmologist, could easily pick this up. It's not too difficult. And of course, as we go from normal vision, subclinical, with essentially a normal presentation of the cornea, through to mild keratoconus, through to advanced keratoconus, we can see more and more severity in terms of the disease pathology. And of course, a decrease in vision as well. Now, clinically, diagnosis is pretty much done based on a range of measures, either using slit lamp biomicroscopy, retinoscopy, keratometry, or topographic imaging, such as pentacams. And this is an example of pentacam imaging, showing a heat map of different elevations of the cornea across left and right eyes. So you can get a whole range of different maps, you can get a whole range of different parameters from these individual machines, and you can make a lot of use of that. Keratoconus is, even though it's relatively rare, it occurs in children and young adolescents. So it affects basically people for the rest of their lives, as opposed to aging diseases such as macular degeneration or glaucoma. And so the impact is basically lifelong. There seems to be an increase in male to female ratio of keratoconus, and there are ethnic differences around the world, and we don't really understand why there are ethnic differences, but certainly in Asia and the Middle East it seems to be more prevalent than in Europeans. And I think this goes with the ethos of GEGC in terms of trying to tease out different ethnic populations and what's going on in different ethnic populations. Prevalence seems to be increasing, and we're not sure whether this is because there is more keratoconus in the world or because there's actually better detection techniques, but it's been going up from 1 in 2,000 to about 1 in 30, some of the latest studies. And it accounts for the majority of corneal transplantations in Australia. In terms of non-genetic risk factors, you probably know, if you're in the area, that eye rubbing, allergy, connective tissue dysfunction and contact lens wear are important factors, but there's also genetic risk factors as well that have come from studies using twins, families, candidate gene studies, and also genome-wide association studies. And if we look at some gene associations that have been reported, you can see this great big long list here, but unfortunately most of these are not replicated and the results are fairly inconsistent, and so it really doesn't really give us a good handle on what the genetic cause of keratoconus is. So previous studies reported around the world are pretty much small. They're around about 100 patients, possibly 100 controls as well. They tend to be underpowered because of this size. Early moderate disease is not that well documented in many studies. Few studies actually combine multiple facets such as clinical, demographic, environmental or genetic risk factors. And so there's many unanswered questions in terms of how we define disease, how we actually look at subclinical disease, how we monitor progression, how we actually classify progression, and how we would actually use this information to improve clinical diagnosis and translation. So the KIC, or the Keratoconus International Consortium, was set up a few years ago by myself and colleagues, and really it was to invite groups all around the world to join together to form a consortium investigating keratoconus. And the idea was that we would collect uniform data fields so that we could talk between the different groups, which is very important. We would collect a defined set of clinical imaging, risk factors, as well as genetic and bioinformatic, biomarker data, if it was available. And this would lead potentially to new treatment options. And of course, we would like to translate these findings back to the patient. And we've already started doing some AI applications on the data that we've been collecting, our own data, but of course we can roll this out to this particular KIC consortium as well. So here's some little boxes in terms of a modular collection system that we set up, because we didn't expect everybody to collect all the data that we possibly wanted, so we defined this as a modular way. So everybody who comes into the study basically gets a standard eye exam in the clinic. They might also get a general health questionnaire. Now, that would be fairly standard information for a patient, but of course you can have other questionnaires that you can ask, such as quality of life, economic burden. You can obtain biometric measures if you wish, and you can also go further and start collecting biomaterials such as bloods and salivas if this is your interest. So the setup was really to ask and collect a standard data set, collect a defined set of core research fields. We asked all the potential investigators who were interested to come together and define what they actually wanted to get in this, out of this particular consortium. We would collect retrospective and prospective data. The data remains a property of the individual members, so it's not something that I have control over. It's if Group A gives some data, then they actually still have control over that data, but they can share it if they wish with the other members. And the studies are basically driven by the members themselves. So the easiest way of collecting this data into a systematic way was really through this platform called RedCap, which is fairly standard now around the world. And it allows you to build questionnaires very quickly. It allows you to export data to common analysis packages. It allows you to schedule visits. It allows you to manage contact lists. And it's also mobile, and it's also web-based as well. So it's a very powerful technique. It's very simple to use, and anybody can enter the data. And here's an example of just page one, which is really just a basic details on an individual, such as their name, the hospital ID, email, etc., etc. So it's just a series of drop-down menus, if possible, to make life as easy as possible for the collecting person. And what we did was we actually collected a whole series of different modules that are listed here, so registration, medical history, and so on and so forth. And we also collected longitudinal data here across different visits. So this gives us an idea of what we need to collect. In terms of data that we've already collected, retrospective, we have 400 individuals from 2 sites in Australia and also Hong Kong, Calvin Pang. We also have some prospective data from China, Australia and Algeria, and we also have another 400 samples from our own previous study as well. So about 1,000 samples already collected for KIC, and this number is rapidly growing as I speak. So these are some of the sites. We've recruited main sites in basically the whole of Australia, and we've also expanded that to the rest of the world. And of course, in India, we have LVP, Naraya and Netralala, and Aditya Jyot in Mumbai. But you can see this is a list of different places that are already being involved in this particular study, and the list is growing. So the outcome of this consortium is really to allow us to collect a large and standardized collection of patients in terms of data from around the world. It will increase our statistical power. It will allow different comparisons between ethnicities and geographic backgrounds. We'll be able to undertake clinical, genetic, and other risk factor information studies, such as looking at disease causation, progression, and response to treatment. And hopefully we can better define early detection of keratoconus and a universally accepted classification system. And also all of this data can be fed into AI applications in the future. So just to thank my co-executive members, Mark Daniel, Elsie Chan, and Srishna Sahab-Jada, and funding sources for this project. Thank you very much.
Okay. Thank you very much, Professor Baird. This is work that Dr. Natarajan mentioned in the previous session, and I also had the pleasure of learning more about it from your associate Srijna in Mumbai just a couple days ago. But this is any questions, any comments, anything that you would like, anyone? No? So Professor Baird is going to be here in other sessions as well as throughout. So please feel free, very approachable. And should we move to the next talk?